So it is June 24th, 2022, I think still is. I'm not sure. I'm not sure if it's 1960 or 2022 at this point. And we're going to start talking today, finishing off the pathology discussion we started last week, ending in neuro. And so now we're going to start with cardiopathology. Then we're going to move on to psychological pathology that I don't have on here that we're just going to talk briefly through because there's not many questions on that when it comes to that. So remember, when you get a question on your boards about cardiopulmonary pathology, it's not only cardiac pathology, but it's also pulmonary pathology, which means you need to make sure that you guys are ready for those lung questions, because honestly, from what I've seen, the majority of the questions are on lungs more than they are on cardio, because there's a lot more conditions that affect the lungs than the cardio side. The cardio side is just heart bad, die. That's pretty much the cardio side of it. We don't see a lot of patients that have a ton of the cardiac issues. So with pulmonary issues, a lot of the questions on your boards are going to get you to try to understand the difference between restrictive airway disorders and obstructive airway disorders, right? So obstructive means that the problem is located where? What would obstructive mean? The problem's located, well, trachea, just inside the body, yes, right? Obstructive means it's inside here. That means it's part of the actual lung system. You know, the lungs, the bronchioles, the alveoli, all that fun stuff. That is obstructive. Restrictive means somebody's giving you a giant hug. That's the way I always think of restrictive, right? So you have that one aunt or uncle who gives those hugs that you just don't like, and they squeeze you to death. That is a restrictive disorder. It means something on the outside of the lungs is blocking the lungs from functioning. Most of our disorders are, you need a giant hug? Yes, so do I at this point. Most of our disorders are obstructive. Very few of them are restrictive. So most of them are inside the lungs and a problem with the function of the lungs themselves. So asthma, and we can almost tie allergies into this as well a little bit. Asthma is obstructive airway disease, can be from respiratory infections, allergies, idiopathic, smoking, all of this comes in with asthma. And you're going to see that almost every single disorder we're going to talk about for the next couple of minutes, smoking is a cause of it. So just don't smoke, folks. So asthma is a restriction of one of the tubes. It could be the trachea, it could be the large bronchioles, it could be the smaller bronchioles. And oftentimes those swell and close off. A severe asthmatic attack can actually block breathing entirely. So we don't, we got to pay attention to that. And for treatment for this, well, obviously there's no way in PT we can treat asthma. Right? It's not like suddenly we make their asthma better by doing exercises. Although exercise does show a positive impact on asthma, it's not going to make it go away, right? You can't tell an asthmatic, go run off your asthma. That doesn't happen. But the main idea with asthma and with allergen-related asthma and stuff like that is being aware if your patient carries an EpiPen and understanding how to use it, because there might be a board question about it. If the patient has asthma and or an allergen where they have severe reactions to stuff, and they start going into, what is that called, where they get a really, really bad attack of this? What's it called when they have a bad allergic reaction or an asthmatic reaction?
Anaphylactic shock.
Good, anaphylactic shock, yeah. So if it's talking about your patient having either really bad asthma and going in anaphylaxis, or a really bad allergen and going to anaphylaxis, and they carry an EpiPen, where does the EpiPen get applied?
The thigh.
What part of the thigh?
The side.
Yes, the lateral aspect of the quad. And a lot of people say, well, isn't that going to not feel good? Yeah, well, not dying feels better. So I think they'll prefer you sticking that pen into their leg than they do that, right? And I could go on about the whole pharmaceutical side of EpiPens. We're not going to talk about that. So we need to make sure we know how to inject that. Can we do that as PTAs? Is that legal? What do you guys think?
I think it is legal.
Yeah, it is.
See why not? Okay.
Yeah, it's considered a life-saving effort. So this isn't one like blood sugar where we can't take it, right? Because that's not considered life-saving, just taking blood. Now, this is considered a life-saving effort, which means you're protected by the Good Samaritan clause, right? So if you stick them and for whatever reason, the EpiPen causes them to now have a heart attack, well, you're protected under that clause. Not that that would likely happen, but. And then the other thing we can teach them is ACBT. And the main part of ACBT that we teach these patients is phase 1, right? The actual abdominal expansion portion, because we need to get them breathing deep. And safety, energy conservation, and then compensation is needed for asthma people. Emphysema and bronchitis are then going to tie together with COPD, so we kind of have to break them down individually. Emphysema is an obstructive airway disease. What happens in emphysema? What is affected? You guys remember?
The space.
The alveolar space, good, right? What causes problems with the alveolar space?
Don't they collapse?
Yep, they start collapsing, and the reason they collapse is because they lose surfactant. Why is my camera flickering? That's going to drive me nuts. So the surfactant, which basically is the WD-40 of your lungs, right? It keeps the actual alveoli patent. It keeps them functional. And so the surfactant gets affected. It basically dries out your alveoli, so they become like dry, crusty little dried leaves on the end of your lung tree. Now, with emphysema, once they start or diagnosed with it, does it improve? Do things get better? Yeah, no, Jason's shaking his head no, right? So once they have it, they have it. It's one of those progressive. Now it can be rapidly progressive or it can be slowly progressive. It just depends upon what their condition is. But yeah, emphysema basically starts restricting their oxygen intake, right? So you're going to see their O2 levels go down because they can't exchange gases as effectively. With that, it's going to be treatment, it's going to be symptomatic, which means we have to constantly monitor their O2 levels. Their medical management is important, meaning they need to make sure they're taking the medications they need to be taken. Smoking cessation is important as well. They need to stop smoking because all that's going to do is hasten the progression. There is no cure for it. And for us, again, we're back to safety, energy conservation, and compensation are the main treatments for it from our standpoint. Bronchitis, right, is an obstructive airway disorder. It's usually caused by colds, viruses, and bacteria. And smoking can cause that, also dust and pollutants. Bronchitis is exactly like it sounds. It's inflammation of what? Can I spell? I'm sorry.
Bronchioles.
Yeah, the bronchioles, right? I know she wants me to spell surfactant. She's testing me. Surfactant. There we go. If you just put WD-40 on your lungs inside, you're okay. It'll work. Trust me. We have an old rule when it comes to rednecks. If it's supposed to move and it doesn't, WD-40. If it's not supposed to move and it does, duct tape. Those are the ways to fix it.
Or zip ties.
What's that?
Or zip ties.
Or zip ties, yeah. Well, zip ties are new, don't forget. We've had duct tape for years. So with bronchitis, it's inflammation of the actual bronchioles themselves, right? And usually the most time we'll talk about it, patients having either an upper respiratory infection or a lower respiratory infection. Have you guys heard that term before? Right? You go to a doctor and they're like, you have a URI or you have an LRI. Upper meaning the upper portion, trachea and those upper bronchioles, lower meaning getting down in your lungs. Bronchitis can be a side effect of emphysema because think about it, if your alveoli aren't able to expand and contract as well, you're going to have a lot more dead air sitting in those bronchioles. And that dead air could have bacteria and viruses, which leads to getting bronchitis. If you have inflammation, so you have that bronchitis going on, could that lead to pneumonia? Yeah. Yep. any inflammation of those bronchioles could lead you down the line of pneumonia because fluid will start building up and then you dry drown. So treatment, again, symptomatic. Airway treatment meds are big for bronchitis. So, you know, your steroids specifically, there are all kinds of new drugs out there that are out there for bronchitis and for asthma. Most of them are some form of a steroid. Smoking cessation is important, your ACBTs. For bronchitis, it's important for the final stage, the clearance, right? You got to get that gunk out of their lungs. For some reason right now, I must be having an allergic attack to something because my nose is clogging up. And safety and energy conservation and compensation. The one thing to understand is with COPD, which we're going into now, COPD is bronchitis with emphysema or emphysema with bronchitis, right? So when patients say, I got that COPD, that bronchitis, and then emphysema, no, you have COPD because you have bronchitis and emphysema. So COPD is a progression of emphysema or a progression of bronchitis. A lot of it has to do with exposures to hazardous chemicals, air pollutants, and smoking are the main reason patients get COPD. With COPD, are oxygen ratings always relevant? So your SpO2, are they always right? No, not always. Right. And so that's why we have to definitely monitor it because maybe their COPD or their SpO2 beating says they're at 90%, which we're like, okay, they're good. A lot of the research out there says that 90% could be plus or minus 5%. So they may actually be 85%, and that's not so good. So we have to pay attention to that. For us, you know, they're going to get their symptomatic treatment, airway needs. For us, we need to get them vertical. Right? The more vertical they are, the more they can clear those lungs out. Smoking cessation, all 3 phases of ACBT, including teaching them what type of breathing. What type of breathing? Pursed lip, yes. Because remember, COPD, the problem is they have dead air in their lungs, and we have to get them to breathe that out, right? And clear their lungs, which means their out phase has to be longer than their in phase. Now, we understand when we teach them that, they're not going to breathe that way all their time, right? So we know they're going to build back up that dead air. The object is to try to teach them at least every so often to kill that dead air in their lungs. So pursed lip breathing is big for COPD. That's going to be one of the questions you'll have on your boards, I guarantee. What in ACBT, what do you teach a COPD patient? And that is pursed lip breathing. CF or cystic fibrosis, right? CF is a genetic disorder. It's a transmembrane conductance regulator impairment. That sounds really, really, yeah, I saw your face there, Riley. That was great. No, just kidding. You don't have to know what's causing it. You do have to know that it is genetic, but I just put that in there so you kind of understand. So think about this real quick. Transmembrane, across the membrane, conductance, the ability to swap back and forth. Right? Regulator controls it, impairment. So it is the inability for the body to control the back and forth exchange of gases. Does that make sense if you break that down? It is a genetic disorder. It is inheritable then. So that means if you have COPD or you have cystic fibrosis, you can pass cystic fibrosis on. There are some small cases of idiopathic cystic fibrosis, and there are cases of teratogens causing cystic fibrosis, right? Real quick, just as because I got this question from one of the students, one of the new students. Are there any teratogens that men could take that could affect the development of baby? Okay, give me one.
Viagra?
What's that?
Viagra?
Okay. Well, I mean, I guess, yeah. But okay, sugars, right? You could pass along some form of sugar disorder. But for the most part, just to be honest, teratogens usually only deal with mom. Because most of us guys, if we take in something that would be teratogenic for our body, what it does is it kills off the ability for sperm to swim. So that means mom's unlikely to get pregnant if the little swimmers can't make it there. Right.
Mr. McKeever, I thought that Dr. Ruskin said things like a man drinking or smoking can like defect the genetics of their sperm. Is that not correct?
It can, but it's a pretty rare case. Right. Yeah. So she has to mention it. But to be 100% honest, a drunk alcoholic man can make a baby just as easy as a sober man, right? And yes, is there a chance for FAST to develop? Sure, there is. But it's more, again, the mother donates more of the genetic code to the baby than the man does. The man really does, I hate to say it, guys, we do donate to it, but we just don't, in the development stage, and this is so appropriate to talk about right now, in the development stage of this, we have kind of little input in it. I'm just saying, we provide that last chromosome and the 23-second side of the alleles, but most of it comes from the X chromosome.
I remember when I was a kid, everyone said Mountain Dew affects your sperm count.
Yeah, it can. Actually can. Well, caffeine can.
Oh, it was Mountain Dew. I always say Mountain Dew. I wouldn't drink that.
Well, that was because Mountain Dew was high in caffeine back then. And now we have Red Bull. So Mountain Dew is weak compared to Red Bull at this point. The other thing I always heard, because I grew up in the IT world, is don't set your laptop on your lap. You'll affect your sperm count. There is truth to that, believe it or not. And again, you notice what that says, though, is it affects the sperm count. It doesn't affect development of baby, right? Development of baby is a lot of mom. And I know it's sad to think that there are some things that are that way. CF specifically looks to be linked to the X chromosome. Now, we haven't determined where yet, but it's somewhere on that chromosome. So, is CF droplet? You can't know. I mean, are they going to have droplets, Brooke? Yeah, sure. Right. You might not want to get them on you, but you're not going to get CF from somebody with CF. So you don't really have to be precautious about that or cautious about it. They're going to have droplets. They're going to be coughing, but you're not going to, it's not like they cough on you, you get cystic fibrosis. Because I don't know that, I mean, that would be pretty impressive for that to cross your gene pool and then change your genes and all that fun stuff. For patients with CF, what's our major treatment? Percussive therapy, right? So helping them clear their lungs. So that also includes ACBT afterwards. They'll take all kinds of medications. We may have to teach the parents how to use vibration vests. Does anyone know what a vibration vest is? It's exactly like it sounds. It's a vest the kid zips on. It's a really super tight, almost like body armor style vest that you put on, because it's supposed to adhere to their body and supposed to, or like the vest that you wear when you're going, you're going out in the lake, the life vests that are really super tight that you wear on water skis and stuff like that. They're that tight. They're neoprene. And then inside them, they have little motors that vibrate back and forth. And those motors cause the chest to vibrate. And because they cause the chest to vibrate, patients can cough up stuff. They're a progression of, we used to, I don't know if you guys are old enough to remember this, but back in the 80s and 70s, we had these giant machines that people used to sit on. It's for home treatment. There are some, that's what I'm going to talk about right now, Brooke. There are some that are actually in the clinic as well, if you work in a pediatric clinic. So back in the 70s and 80s, we had these giant machines that people used to get on to lose fat. They'd get them on and this belt would go around their waist, and that device would just shake them back and forth, back and forth, back and forth, and supposedly it destroys fat. Well, ironically enough, we realized those are really useful for kids with CF because it shakes them back and forth and it kind of breaks up the mucus in their lungs and allows them to cough it up. So, Brooke, we may not get the vests in the clinic, but a lot of times if you're working in a clinic that has pediatrics and sees a lot of CF kids, they have those machines that kind of basically shakes them to death. Not to death, but you know what I mean, that'd be bad. No shaking kids to death. But causes them to vibrate rapidly in order to cough that up. A lot of the kids will prefer that to percussive therapy because they don't like the constant pounding on them, right? So it just depends upon what your clinic has. Safety, energy conservation, compensation. Nowadays, kids that have a cystic fibrosis disorder, or even young adults that have cystic fibrosis disorder, can live longer than they used to. right? With the medications out there, you can live a fairly functional life with cystic fibrosis. But with cystic fibrosis, it's going to put you at risk then for asthma, bronchitis, emphysema later down the line too. So all those lung disorders. Pneumonia, or as patients call it, I have ammonia. Ammonia is a totally different thing, right? What is ammonia? Ammonia is NH3, if I remember correctly. So nitrogen trihydrogen. Nitrotrihydrogen, I think is what ammonia is. Anyway, but I just taught that. Pneumonia can be caused by pretty much any infection that attacks the lungs. Primarily, the two main types of pneumonia are bacterial and viral. Which one of those would you hope to get mainly if you're going to choose? If you had to choose, would you rather have bacterial pneumonia or viral pneumonia? None is not an answer. Okay, so Riley says viral. Okay, Anthony says bacterial. If you had to choose, bacterial is usually less of a problem. And there's a reason why. We have a lot more antibiotics than we have antivirals. Does that make sense? And the antivirals are really hard to use because they may not always attack the right virus strain you have, right? So technically antibacterial, but which of those is more contagious, bacterial or viral? Other way. Just remember one thing, for when it comes to patho, bacteria spreads easier. Right? So just think of it that way. Bacteria spreads easier. I'll answer your question in a second, Joe. It's okay, right? That's why I ask these questions. Why does bacteria spread easier? It's able to reproduce faster. Right? What does a virus need to reproduce?
A host?
Yeah, host. It needs DNA, RNA to reproduce. Bacteria can actually some bacteria can reproduce asexually, meaning literally just by splitting cells. So that's why bacteria, like when we talk about, I don't know if I mentioned meningitis last time, but we talk about meningitis, right? Bacterial meningitis is the one we worry about. Because like, let's say we're back in class and Jason comes in with bacterial meningitis. We have to test the whole class at that point because bacterial meningitis spreads like a wildfire. There was a case of that back in Pennsylvania. Did you guys have Chi-Chi's on the West Coast? I can't remember if you did or not, the restaurant Chi-Chi's. I don't think you did. So Chi-Chi's was an upscale Taco Bell. That's the best way I can put it. Chi-Chi's was a sit-down Taco Bell. You went in and you ordered from an actual menu, but it was still Taco Bell. But back in the East Coast, in Pittsburgh, they had this one Chi-Chi's where 3 of the cooks had bacterial meningitis. And they didn't report it, and they came to work. This is why you should stay out of work when you're sick, right? And it infected like 2,700 people. Because the people that came to the restaurant got bacterial meningitis, and then where did they go? They went to home and work, which infected more people with it. And they had this huge outbreak in Pittsburgh of bacterial meningitis. So bacteria spreads a little easier. Joe asked, what is walking pneumonia? How to show up on a practice question. So walking pneumonia is a bit of a misnomer because walking pneumonia means you're starting to get fluid in your lungs overall, but you can function. When we typically think, sorry, I'm responding to Dr. Reskin here. When we typically think of pneumonia, usually it's going to knock us on our butt, right? And it usually is going to require bed rest. If your doctor diagnoses you with pneumonia, it means you're typically on bed rest. Walking pneumonia means they're actually able to get up and function. If you happen to remember what the question was asking about it, Joe, I can maybe give you a little bit better kind of insight into it. But walking pneumonia, guess what we should probably do to them? Walk them. Because again, the more they're upright, the better it's going to clear their lungs. Unless the doctor, of course, says no walking then. But usually in the case of diagnoses, if a doctor diagnoses you with walking pneumonia, it means you have a less severe form of pneumonia. is there any specific type of pneumonia we have to worry about here in like the Southwest? Have you heard of any specific disorder that can cause pneumonia here that's unique to our area? Have you heard of desert fever? Desert fever is a myconiid disorder. So myconiid means it's fungal, right? So succulents and I can't remember, are cacti actually classified as succulent? I can never remember that. I always get confused. But anyway, cacti and succulent have a certain bacteria that grow on them. I'll look that in a second there, Anthony. Just give me a second, because I want to keep going down this path real quick. They have a certain bacteria that grow on them that, especially during the first beginning of spring, when they start blooming, they kick off that bacteria and it goes in the air. Now, most of you guys, if you've lived here for at least 5 years, have built up a certain immunity to that because you've encountered it, you breathed it in, you built the antigens up for it. But a lot of times patients can come here, or people can come here, excuse me, especially here in Las Vegas, where it's a travel town, right? And during the spring, they'll get exposed to that myconid and they'll end up with, you know, what's called desert fever. And it's a really debilitating form of like a lung disorder, along with they can develop pneumonia from it, but it is fungal. And treatments for fungal is literally simple, antifungal, right? All right, so let me read this question. A bacteriatric patient with walk pneumonia has a history of recent falls and receiving physical therapy for general strengthening. Our patient treatment is most affected by this lung condition. Number one, I don't like this question. Where did this question come from? So that I can say I don't like it. Okay, yeah, I already don't like this question, Joe. Thank you for at least bringing it to my attention, because I'm guessing, I'll take any other questions. Well, I'm working with them on that, Anthony. You got to realize that some of they think a lot more from the PT perspective than from the PTA. All right, so let's go for a vote. If those who haven't taken it, what do you guys think it is? Okay, so I got 2 1s now. For some reason, I'm going to guess they're going to say diminished tidal volumes. What did they say for this, Joe? Okay, so they said 1. Okay, good. All right. That was what I was hoping. That at least makes me feel better. But I was really certain, because I've seen a couple of their questions where they're really going into the science of it, and diminished tidal volume would be the most scientific answer. So that was what I was like, wait, don't tell me they picked diminished, because yeah, decreased stamina and tolerance is obviously going to be the major thing, right? But 1 and 2 are the same answer. When you look at that, right? 1 and 2 are the same answer. If you have decreased stamina tolerance, you have inability to participate in endurance. So that's why I'm looking at this going, that's why I don't like this question. And 3 is a right answer, because it does diminish their tidal volumes. But lower oxygen, that one you could throw out. That's not necessarily a necessary one. But yeah, looking at this question, I mean, like I said, from a scientific perspective, I was figuring they're going to go with 3. Now, the PETA is intentionally not as tricky, and that's why I prep you guys in advance, right? But looking at that, I mean, I want to, do you guys know which one of the tests that was out of? Just because I want to send Dr. Crane an email about it. Test 3, okay, thank you. I know how much people love getting emails from me. It wouldn't be that tricky or confusing. So in that case, if I was writing a board, so I can tell you right now from that question, if you sent that, if you were an item writer and sent that in, that would have to be sent back. That would not be acceptable because 1 and 2 are too close. Yeah, it's going to be taken out. Yep. But what they would say is, good question, let's make it better. And this is how they do item writing. So they would send it back and say, well, 1 and 2 are too close, and 3 is too close to the scientific answer. So 3 would be your first elimination. So we might change it to something like impairment of the oxygen exchange capacity. Now that one obviously either has to do with emphysema or cystic fibrosis, right? So that's not a pneumonia issue. And then I would change 2 to something like inflammation of the bronchioles, right? Now that would be more along the lines of bronchitis. So now the only answer you have left is decreased stamina. Oh, you mean when you're doing the PT final? Is that what you're talking about, Joe?
Yeah, like, so when you're like reviewing it after you've taken it, you can't report the question because a lot of their rationale is like either it's a typo or it's not correct and you can't report it there. And I don't want to like send them DMs.
No, actually, I want to know, you know what, though, I know that's supposed to be there, so they might not be aware it's not there. So
Gotcha.
let me email, like I said, I'll Dr. Crane, I keep wanting to call his first name, but I should really refer to him as Dr. Crane. He and I are on pretty good terms, so that's actually good feedback for him. So I'll send that in to him because that would probably be something they'd be interested in. And one of the things I suggested to him also is to put a feedback section on when you guys do the review. So if you wanted to give feedback, you could. Because honestly, it's the only way they're going to grow. And that's how score builders initially did it. When you completed the score builders test, they asked you to fill out a feedback form. So I'll make sure that that there are a couple questions that I've gotten sent to me this week about that too. So it's not only you guys. But yeah, back to pneumonia. For us, it's getting them vertical, getting them out of bed, even if it's just out to the chair and teaching them ACBT and clearing their lungs. We can't clear all of that pneumonia out, especially if it's deep pneumonia. Does anyone know how they actually treat it if the patient's lungs are too full and they can't clear it? Does anyone know what they do?
Do they drain the lungs?
Yes, they do an aspiration, right? And what they do is they literally stick a needle in between your ribs into your lungs and suck the gunk out. My wife who passed away got pneumonia from her lupus. And it was really interesting. It was really interesting from my standpoint to see. It wasn't so interesting from her standpoint to see because her lungs filled up with interstitial fluid. And so at one point she was 60% blocked on her left lung and 40% blocked on her right lung. And they had to go in and drain the lungs. And when they did it, they pulled out, and the fluid that came out, you would think would be like this infectious, green pussy fluid, but it looked almost urine-like is what they drained from her lungs. It was this kind of yellowish, brownish fluid they drained, and it was kind of gross. And because one thing just to be aware of with pneumonia, if you've had pneumonia, there's a highly good chance that your lungs will never be the same from then on. Usually it causes scarring. And I can speak from experience from having the wonderful disease that's going around right now that we don't want to mention because YouTube will demonetize me, even though I'm not monetized. That wonderful disease that is going around that we can't say, that scars the lungs too. And when they get scarred, your lungs don't function as well anymore. So that means energy conservation compensation is big for these patients. What if the patient can't stand up? If we get a question, the patient has pneumonia, but the doctor has ordered for them to be positioned vertically, what can we use? Tilt table. There you go. Good. No problem, Jason. All right. So that's it for those pulmonaries. Let's talk about aneurysms. Aneurysms is nothing more than a ballooning of the blood vessel, right? It's a weakness in the blood vessel walls. It can be a congenital defect. And let me get my little drawer tool up here. So here's my normal blood vessel, right? Then we can have an aneurysm that looks like this. And then we can have an aneurysm that looks like that. Doesn't matter what the aneurysm looks like. The aneurysm is an aneurysm. So this is your normal vessel. Why am I? That's weird. Does anyone remember what this aneurysm is called here? I think it's my mouse software that's causing the problems. That's called a fusiform aneurysm. And then this one here forms a sac. So this is called what type of aneurysm?
Sac?
Yeah, saccular.
Tackle.
Yeah, saccular, saccal aneurysm. Right, so that's kind of the forms the aneurysm takes. The main thing your board may ask you is which of those is more likely to pop? What do you think? The fusiform or the saccular? Yeah, saccular is more likely to pop. Good. Which of those is more dangerous to the patient, though? The fusiform. Yeah, right. So think of it this way. The saccular is more likely to pop because it's a localized small ballooning, right? But it's going to be a small hole. But the fusiform is the actual blood vessel itself that's expanded. So if it pops, bad things are going to happen. So an aneurysm is weakness in the walls. Smoking can cause it. What's it called? Artery sclerosis can cause it to happen. All those fun things. Anything that affects the blood vessels can cause it to happen. How do they treat it? Well, in medical management, they may have to give them anticoagulants, meds that help with blood flow, safety and energy conservation and compensation are going to be our thing. If they have an aneurysm somewhere in their body, it is going to probably rupture at some point. Now, they do have sleeves they can put over the outside of like the fusiform aneurysms. It's a kind of complex procedure. If it's something specifically, if it's like the AAA, have you heard of the AAA aneurysm before? Does anyone know what that is? So A. Abdominal aortic aneurysm. That's driving me nuts. Right? So abdominal aortic aneurysm. So that's an aneurysm of the aorta as it's kind of descending. Would that be problematic? That sounds bad. Yeah. Anthony's right. That sounds bad. Right? And so a lot of times they may have to sleeve that aorta, or I don't know if they, I don't honestly know if they do, it's pretty empty vessel. I don't know if they do like bypass on that or what they do totally. I just know I've dealt with most of the patients I've dealt with that have AAAs eventually die, unfortunately. Right? Because once it pops, yeah, you're in trouble. That's going to bleed into your internal cavity and you're pretty much done at that point. But if you get a question about abdominal aortic aneurysms, basically no bad case scenario, right? That patient, you're going to want to monitor all of their vitals at that point. I don't think you'll get questions on it, but you may see it when you're working in the cardiac wing if you ever choose to do that. I love the next one, angina pectoris, because what does that literally mean? Oh, wait, here, when we get the chance, can we go? Yep, that's coming up. That's actually coming up here, Brooke. So give me a second. We're on here for just a second. I'm going to stop screen sharing for just a second. I want to shut down my software from my mouse real quick. Hold on one second. So stop share. Give me just 1 second here. All right, so I can start sharing again. Sorry about that. It just seemed to be freaking out on me, so I want to try to see if that fixes it. All right. So yeah, we'll go over the wounds in a second. So I'm going to talk about PAD and PVD in a second. All right, so angina pectoris. What does that literally mean? Chest pain. Yeah, that's why I always love this. This is a disease. Well, not really. It's just chest pain. With angina pectoris, you have to understand the three main types. And that's exertional, spontaneous, and vasospasm. Okay. And I always chose to remember them by the way they were actually described. Stable, unstable, and what's called variant chest pain. Right? So stable means they only get chest pain. If it's exertional, they'd only get chest pain when they do what?
Exercise.
Exercise. Good. Yeah. Right. So they only get that chest pain when they exercise. Why did that go away? I don't want that to go away. Unstable or spontaneous means it's going to happen when? Yeah, random, right? A lot of these patients, they'll complain that they get chest pains when they lay down for the unstable ones. Right. So say every time I lay down, I start getting chest pains. Well, there's reasons for that, right? They've got all the weight of their chest now on their heart. And if they've got, big belly, that's kind of weighing down as well. So that can be problematic for it, right? So unstable just happens whenever. And then the variant or the vasospasmic happens typically when they're in the phase of blood pressure where it's contracting. So in that, the systolic portion of blood pressure, and the heart muscle then kind of spasms out. It's inadequate blood flow, right, to the heart of some types, right? So it could be from other heart conditions, can be from whatever. With angina pectoris, for us, we have to monitor all the vitals plus RPE and be paying attention if they get pain from it, right? What if you've got a patient and you're working them out and they start getting exertional angina pectoris? What should you do? Well, stop working them out, right? That's the main thing that's going to be coming up in your boards, right? Nitrates are big for that. Yes, Brooke, that's going to be the meds they take for it, right? But in general, for us, they'll say, your patient has a history of angina pectoris, and while on the treadmill, the patient begins to experience minor discomfort of the chest. Would you A, continue the treatment, B, call an ambulance, C, give them medication, or D, discontinue treatment at that time? You discontinue treatment, right? Stop and then continue to monitor them to see if it gets better. If it doesn't get better, then we might call an ambulance, right? So just understanding monitoring is big for them. That's the big thing. We need to monitor everything: RPE, pain, vitals, shortness of breath, right? Because it doesn't take much to go from angina pectoris to an MI, right? So myocardial infarction. We can't monitor meds. We can tell them that, if they're having chest pain, to follow their meds precautions, because some people carry nitrates, Anthony, and they're supposed to take it anytime they get chest pain. So we can get their meds for them. We just can't put it in their mouth, if that makes sense. Right? So if they're sitting on the treadmill and they're like, hey, can you go get me my meds? We can go get their meds. We just can't stick it under their tongue. Same idea with like blood pressure or blood sugar meds, right? We can't stick them with their insulin, but we can get it for them. Arterial sclerosis and athelar sclerosis, I feel like I beat this horse dead already. Right? Athelar sclerosis is a progressioning of arterial sclerosis. It's a narrowing of the arteries with collection of plaques. Smoking is the big cause of it, but also bad cholesterol being too high is another. Right? So the patient needs to be monitoring for that. What type of meds are they going to be on if they have high cholesterol?
ACE inhibitors.
Could be on ACE inhibitors. And then what's the other one? The statins. Right? And then treatment's going to be medical management, medications. For us, observation and changes in cardiac symptoms. So noticing if they get angina pectoris. Stress management is big, because stress management actually can make arterial sclerosis work. Stop smoking, please. Safety, energy conservation, and then compensation are big for us. You're going to notice that's pretty much the answer for all of these. All right, now we're going to talk about venous insufficiency, which leads to the PVD, and then also PADs here, which is Brooke's question. All right, venous insufficiency, which can lead to venous wounds, is usually caused by weakness or damaged valves in the vessels. So this isn't the valves of the heart. This is those little valves in the venous, in the veins that stop backflow of blood, right? So as blood pumps up from your legs, it moves up in the veins, and then a valve closes to keep it from moving backwards. And then it moves up, another vein valve closes, and it keeps moving up, and those valves close. When those valves become less patent and less functional, now that blood can backflow and pool. It will happen to us eventually. It all happens to all of us as we age. Ladies, unfortunately, you get it more frequently, especially if you've got any issue with your hormones where you're taking hormone replacement therapy. That can affect it. Smoking, obesity, what? Smoking, obesity, hold on a second. My system seems to be freaking out here for some reason today. All right, let me quit out of everything that sends notifications over to me. Let's do that. Sorry about this. I think it's because there's a Windows update updating right now and it just is screwing with everything. I should not have clicked OK to update Windows. So when you have that venous insufficiency, again, the blood's going to start pooling. Pregnancy can cause this too, and immobility. So what happens? Well, what causes the veins to pump the blood back to the heart? What is the main reason? I don't have too many USBs plugged in. I don't know what you're talking about, Joe. Stop it. And there's a reason why I have a hub instead of plugged directly into the system. What causes, what causes the blood to go back? Us doing what? Movement. Right? The veins don't have a pump themselves. Movement's what pumps it back, right? So for patients that have venous insufficiency, it means they need to get up and move, even though they don't want to, right? Because they can get pain with it, dull aching. Excuse me. And then treatment for this, right? Obviously, we're going to get them moving. Medical management is the big one. So they need to get the medications that they need to be on for the actual, whatever disorder's causing their venous insufficiency, right? Compression garments are big. Typically, the compression garments are going to be less than 80 millimeters of mercury. Why would that be? Why would they be less than 80 millimeters of mercury?
So that it doesn't raise your blood pressure?
Which blood pressure?
Diastolic.
Yeah, diastolic, right? Usually we try to keep it under diastolic. Lower extremity elevation's big. Safety, energy conservation, and compensation. So with venous insufficiency, right? That means we are likely to see venous insufficiency wounds, right? Or venous wounds. And then we're going to have PAD wounds over here. Good. All right. So he's already on this idea, right? Which one is the zombie bites, Anthony? The venous. Good, right? The venous wounds look like zombie bites, right? So the way I always remember this, are venous medial or lateral on the legs?
Medial.
Good, they're medial, right? And we're just gonna go down the line here. We'll talk about PAD in a second, but we're just gonna go down the line into it. So that means that arterial then would be lateral, or the other thing, oh, that was good. They can also be anterior. So on the front of the leg, typically, right? So venous are medial, right? And then arterial are typically lateral. These look like zombie bites, which means the wound edges are what?
Ragged.
Ragged. Yeah, they're uneven or irregular. Versus arterial are smooth, right? Often arterials look like little circles. They're not well defined, right? The venous ones are not well defined, and the arterials are well defined. Oh, there's what's causing it. It just popped up. Good. Thank you, Synapse, for updating. That's great. I appreciate it. With venous wounds, a lot of drainage or no drainage?
No drainage?
Do I have a second vote? So with venous wounds, we have moderate to heavy. No is over here on arterial or little. Now there may be some arterial wounds that bleed, right? Yes, it pools, so heavy drainage. Exactly, Anthony. That's the way I remember it, is because venous wounds are pooling, they have a lot more heavy drainage. And is it blood? No, typically it's interstitial fluid, right? It's goopy, it almost looks like edema drainage, right? So there's usually heavy drainage. And then for venous insufficiencies, what's the pain like? Alginated is, you're exactly right, Anthony, good job.
There's no pain with venous.
Right, no pain, no or little, right? I'll just put little pain. But because arterial happens during the pumping, there's usually a lot. Right, or severe pain with arterial wounds, right? So that's usually how you identify it. So now that actually brings up a good point that Anthony brought up. Usually that means venous wounds are going to lend towards our alginates. And venous usually has hairless as well. Yeah, the hair is going to kind of, actually they both can, if I remember correctly. Hold on, let me just double check. Yeah, no, I mean, venous, no, arterial has more hair, but they both can lead to hair loss. So there's not going to be a specific, unless you got a question on that specifically, Brooke, they usually don't ask about hair loss because they both can cause hair loss. Venous is typically, venous typically has more, but they're both going to eventually cause hair loss in that area because arterial is eventually going to cause there to be no arterial flow. I don't like that. Venous usually causes it first, though. I usually talk about what the skin looks like more than the hair loss. So with the venous wound, what's your major clue that it's a venous wound? What does the skin look like? Yes, okay. So yes, with venous, it's usually dry, flaky, and have a yellow appearance. Arterial is thin and shiny. Right, those are your main keywords with that. And I wouldn't say in yellow, brown, whatever you want to call it. So a lot of times with wound care, what they're going to talk about is either identifying whether it's venous or arterial, or then the dressing. Right? So with venous, we're probably going to lean towards our alginates because they're going to have pretty heavy drainage. With arterial, we're going to want more cushioning. Right? Because a lot of times those are going to be painful and you bump them and they're going to hurt a lot. Right? And there's typically no drainage. We may actually have to add moisture to the wound. So we may actually have to use somewhat to add moisture.
Hydrocolloid?
Hydrogels. Yeah. Hydrocolloids are also drainage, but hydrocolloids are also what we use to protect wounds, right? From poopy stuff. Right? So yeah, the hydrogel stuff. So that's the main idea with those wounds. The only other wound we have are the neuropathic or the diabetic wounds. And where do most of those occur at?
Plantar
The
surface.
Foot.
Yeah, the bottom of the foot. Yeah, plantar surface of the foot is the main area, right? And they are well defined. They look like a combination between a venous and an arterial wound, right? But if it says something, yeah, if it says something where it says plantar surface of foot, automatically go diabetic or neuropathic ulcer, right? The terms are used synonymous because diabetes is going to cause you neuropathy. And then if it's asking for dressings, you just go on what it says, right? If it's on the plantar surface, obviously we're going to want cushioning. If it's got heavy drainage, we got to deal with the drainage. If it's dry, we got to deal with the dryness.
Mr. McKeever?
Yep.
When does only diabetic wounds use antimicrobial dressings? I had a question on that.
Well, any wound can use antimicrobial dressings if they're what?
Infected?
Infected. Yeah.
Right.
So it doesn't matter what the wound is at that point. The key is it infected? And what would be signs of infection?
Like redness or heat and
Good.
like pus.
Yep, pus. That's a major one, right? Redness, heat, pus, or the other term for pus when it starts breaking down is slough. right? If you have a lot of new slough in the area, because that's white blood cells, right? So that's pussy, gooey goop. There might be a sign that it's infected. If you have other signs that go along with it, like some heat and some redness. Now, some slough is natural in wounds when they're draining, but if it's an excessive amount and you're noticing redness and heat, it's probably infected. And then we do want to use antimicrobial dressings. Your boards are probably less likely to ask you about antimicrobial and more likely to ask you about when to use an alginate versus a hydrogel, because those are the more common questions. Or using a foam. When would you use a foam dressing?
I would say like depending on how deep the wound is.
Not necessarily. That's going to be packing.
Oh,
Heel core pressure, good. So over big bony prominences or areas that we bump frequently, right? So the sacrum, we probably want a foam dressing there, right? Or if we have ischial tubes that are problems. The malleoli, we probably want some foam over the heels, anything like that. Foam is often used for pressure relief.
I had a question about debridement. Do you think that we're going to have to worry about selective and non-selective debridement in reality, or is that a PT thing?
It's more PT, and from our standpoint, when it talks about it, what I've seen for questions on the boards about debridement there is it'll say that, you know, which of the following types of debridement is contraindicated for PTAs and what one's contraindicated?
Sure.
Sharp, that's it. Yeah, that's the major one that they ask on the boards is what can't you do, right? And Sharp's debridement is tool debridement. So any type, and as far as the boards are concerned, it's any type of tools you use to debride. So scalpel, forceps, all those fun things, right? But what about enzymatic, autolytic, all those? Is that within our scope of the wheelhouse to use? Yeah, those are allowable, right? It's just that Sharp's debridement that's not allowable. So that's the major thing. Now, you know, when to use what, that again gets more into that pure wound care specialist field. Because I'm going to be honest, I've done wound care for a lot for a lot. That's good English there. I've done wound care for quite a while, and I still get confused when I want to use an autolytic versus an enzymatic debrider. And it just kind of goes along what I'm seeing. And especially with these, the wound care questions on the boards, unless there's a picture, it's really hard to tell you what you're seeing, right? And now they are voting to put more pictures on the boards, but that wouldn't happen until 2023, 2024 at this point, so you're safe. There are some pictures, but they really want to add lots and lots of more pictures, and I don't always like that idea because that gives you more for your brain to absorb and screw up. Does that help with the wounds there, Brooke? Okay, good. So going along the lines of those wounds and going to peripheral artery disease. Excuse me, peripheral artery disease is usually caused by arterial sclerosis, which means it can also be caused by Athelar Sclerosis. Blood clots formed in the veins, aortic dysfunctions, all other heart problems can lead to peripheral artery disease. When we talk PAD, the main thing that you're going to get questions about with PAD is, what is that term when they get the dull throbbing in the legs?
Intermittent claudication?
Intermittent claudication. Yes, good job, right? So they'll talk about intermittent claudication or the throbbing of the legs, right? And that is usually dealing with, so if they say your patient has, you know, this dull, achy throbbing occurring during exercise or when they elevate their legs, which of the following disorders is likely to cause that? That's peripheral artery disease. If it says you wanted to test peripheral artery disease, how would you test for that? What would you do? Elevate the legs. Yeah, you just reverse the question, right? So you'd elevate the legs or give them moderate exercise, right? So moderate exercise would be like putting them on a treadmill and getting them going a little bit, stuff like that. Yeah, the funny thing about PAD is moderate exercise exacerbates it. Yeah, it just makes the throbbing worse. And you got to think about it, Brooke, from the standpoint, peripheral artery disease means the arteries can't pump right. So by elevating, you're making it harder for the legs to pump the blood up to the feet.
Okay, I feel like I just get confused with like the wounds and then like the different diseases. So I thought one of them was contraindicated for like raising the legs, or like patients get really mad when you raise the legs because
Yes, that would be PAD.
Oh, okay. That
Right,
doesn't
and-
have to do with the wounds at all?
Well, yes, that would mean that with the peripheral, if you have a peripheral artery wound, you're going to have the same problem,
Okay.
right? So anything dealing with the anything typically arterial, elevating the legs is going to make them more uncomfortable. That's why we would test that way, because if we elevate the legs and they start getting exacerbation of the intermittent claudication, we can pretty much say it's peripheral artery disease. Does that make
Okay.
sense?
Yes.
Yeah, venous wounds, we're going to elevate the legs because we got to get the fluid back to the heart.
Okay. And for arterial is like compression stockings contraindicated?
Yeah, yes, it would be typically contraindicated because now you're restricting the blood vessels even more.
Yes. Okay.
Versus venous wounds, they would be indicated.
Okay. All right. Thank you.
That's okay. Joe, I totally lost my train of thought there. What was the positive indication? What are you talking about? Oh, the positive indication of pressure at rest. Is that what you're talking about?
Yeah, is it like they have intermittent claudication if they
Yes.
still have pain at rest?
Yeah, so it's intermittent claudication may occur, and as PAD gets worse, that intermittent claudication is going to get worse and more frequent. So now they're going to be sitting at rest and be like, yeah, now I'm getting the dull throbbing, and they're going to feel like they have to get up and move, and then they get up and move, and the dull throbbing happens again. So it's this really obnoxious kind of vicious cycle that happens as that gets worse, right? And the medications are going to be the main thing that's going to have to help it. Because ultimately we can't, stop it from happening, if that makes sense. The only thing we can do is teach them what makes it a little better and what makes it a lot worse. I can't figure out if Riley's typing me something or if she just looks really aggressive. Okay, it's checking. Sometimes I see your arms go down like that, you're getting ready to type something in. So I watch you all. No, just kidding. Does that now kind of clear up PAD and venous? Are we good on those? Overall? Okay. Cor pulmonale. So just to put you at ease for this is a life-threatening condition. If they start showing signs of cor pulmonale, we would call a code or call 911, depending upon if we're in a home health setting or if we're outpatient or if we're in the hospital. Cor pulmonale is a rapid increase of pulmonary blood pressure. Right, that's what literally it says, cor, right, pulmonale, rapid increase of blood pressure of the pulmonary arteries and veins. It's usually caused by pulmonary edema or swelling in those veins, right? What would be a sign that your patient suddenly is going into cor pulmonale? What do you think? So the lungs have suddenly got massively backed up. Dyspnea, real bad dyspnea, Anthony. Right, so a sudden onset of really nasty shortness of breath. And when I say shortness of breath, I'm not talking like we just ran a mile and we all feel like that, right? A little short of breath. I'm talking the patient cannot gasp. So what are they going to sound like breathing? Right? They cannot catch their breath. They can't get enough air in. So for us, what are we going to have them start doing immediately? What do you think? What's the first thing we're going to start them doing?
Focus on their breathing,
Yes,
segmental
good.
breathing.
Yep, we're going to do segmental breathing, at least until we can get help, right? And so just to let you know, when I looked at this, because I was looking at this last time, I'm like, I don't remember if we lay the patient down or sit them up. It seems to be the research is 50-50 for what you're supposed to do. So I wouldn't change their position and let the medical professionals decide what they're going to do for their positioning, right? For you, just keep them where they are and help them breathe a little better. If they're already on supplemental O2, make sure they're back on their supplemental O2 at that point. So if you took maybe their oxygen off to exercise, make sure you get their cannula back on. you know, they're gonna have to manage, the doctor have to manage their medication. But for us, they'll say that, you know, you're working out with your patient in the cardiac wing and the patient suddenly develops a rapid onset shortness of breath and their vitals seem to be going out of whack and their SpO2 falls. What do you suspect this patient of having? That would be cor pulmonale. And that is a medical emergency. They need to get care right away. Because literally, think about this. The blood vessels in the lungs are only, there's only a set of them, right? If one of them pops, that's bad, right? You're going to lose a lung. So that's cor pulmonale. Coronary artery disease, or CAD, right, is damage to the inner layers of the coronary artery lumens. So if I say coronary artery disease, where are those arteries located at? The heart, right? So CAD is pad of the heart. Does that make sense? Because peripheral artery disease, yeah, I see, right? I saw a light went on in Riley's head. I could actually see the light light up, right? So, right, so this is where the arteries in the heart themselves start having problems. It could be aneurysms, it could be from LDL, HDL imbalance, nutrition, smoking's the big one. For patients with coronary artery disease, they are at high risk then for all of the other disorders of the heart, right? So heart attacks, strokes, peripheral artery disease, all that fun stuff, cor pulmonale. So that means they need to stop whatever's causing the coronary artery disease, whether that's eating really bad foods, right? And unfortunately, for most patients that develop coronary artery disease, yep, go ahead, put it in there. For most patients that have coronary artery disease, they're gonna have to stop eating what type of meat?
Red meat.
Red meats, yeah. Right? And Bianca would have been happy to hear that, saying that we have to stop eating meats, I'm sure. So let's see what it says here. Physical therapist assistant who attempts to assess patients' relative risk for developing coronary artery disease, which the following scenarios would result in the patient being at greatest risk. Wow. That's really specific. And that's almost in diagnosis category there. But I'm like looking at this going, this is really, really, really specific, right? So let's take a vote. What does everyone think? Okay, so we got 1, we got no idea, we got 3. Which one did they pick, Joe, for that?
3.
Okay.
Score builders exam 2.
Yeah, score builders exam 2. Yeah, this one's really specific. And the main thing I'm looking at here is all of those are at risk. But anytime you go over 200 on total cholesterol, that's really, really bad. Yeah, the doctors are now saying, Anthony, 100 to 130, I think is what they're saying now. They're even kind of erring on the side of cautions, but I think your book says 120 to 130. But like from what I'm reading in the journals, they're now saying like 100 to 130. It's kind of like we used to say that 120 over 80 was normal blood pressure, right? And now we say that's pre-hypertensive. So yeah, so the main thing, what I'm looking at here, if you get a question, something along the lines of this, if it's got a blood cholesterol over 200, that is like a heart attack waiting to happen. To put that in perspective, my mom, when she was having her heart attacks, her total blood cholesterol, total serum cholesterol was 333. Right? That tells you that that's bad, right? That just basically means that your blood itself is filled with goopy fluids. So that would be the, and males or females, yeah, males with the cholesterol over 200. Yeah, I would just mainly say that anything over 200 at that point, Joe, I'm gonna pick that answer 9 times out of 10. But man, man. I don't think you're going to likely get one like this. They may ask you which of these cholesterols is worse, and you have to know that over 200 is definitely worse. But I don't think they're going to. That's way too close to diagnosing. Ugh. It's gonna make me angry at score builders. So yeah, that's CAD. The main thing with that is cholesterol and smoking. Smoking, like, when I was looking into this, smoking, there's something that they said that a smoker is like 5 times greater at risk to develop coronary artery disease and peripheral artery disease than somebody that doesn't. So like that alone should be enough to make you not want to smoke. All right, DVTs, deep vein thromboses. And the main thing is any condition that can impair circulation can cause DVTs, including surgery, sedentary lifestyle, anything like that. For us, as far as the DVT goes, the main thing you want to pay attention to for us, as far as DVT goes, is if they have a known DVT, are we going to get them up and out of bed? What do you think? Nope. Yep, that means they're on precautions at that point until we get cleared. Right, so DVT is definitely can turn to a PE, or worse, Brooke, it could turn to a full-on stroke of the brain too. Right, depending upon what happens. So yeah, for the main idea here is definitely we don't want them up and moving if they've got that DVT going, right? So if they've got a DVT, nope. The test for DVT is Homan sign, right? What are the parts of Homan sign? Pulmonary embolus, yes. Don't get confused with pulmonary edema. I used to do that all the time, Anthony. So what are the signs for Homan sign? First of all, where are we testing at?
You're testing their calf, and isn't it pain?
Yep, so pain is the first one, right? Warmth. What are the other signs of inflammation? Redness, maybe a little swelling, right? And then you put pressure between the heads of the gastroc. And if the pain gets increased, they have a positive Homan sign. Does that mean they automatically have a blood clot? No. But it's a good chance that they have one. And at that point, we probably want to say, let's hold off and get you screened. Right? And they may have to put surgical filters in place for this, meaning they're filtering out those blood clots. And then we have to pay attention to either signs of a heart attack or stroke or a pulmonary embolus, so they start having problems breathing. Oh, I gotta stop writing. Here, my writing. All right, congestive heart failure. Be aware, because I saw a question about this on, I think, one of the recent, I don't know if it was a Pete or not, but somebody asked this question. With congestive heart failure, it is progressive. That means once they have heart failure, they don't get better, right? It's not like magically we can fix the heart without replacing the heart. So we are no longer going to get them back to pre-morbid condition at that point. We are going to mainly help them live with the condition they have. Smoking is the main cause. Nutrition, age, diabetes mellitus, previous myocardial infarctions, heart valve issues, previous strokes, any cardiomyopathies. There was just a research put out right now today. I was just reading it before a class, or before this, talking about the risks of patients developing a cardiomyopathy with the Moderna vaccine. Because all vaccines that are dealing with COVID have a risk of cardiomyopathies, but the actual research found that the risk of developing the cardiomyopathy from COVID is a lot greater. And they're actually thinking, how many of you guys saw the NFL player that just died? Did you guys see the information about that?
Was it Tony Saragusa or?
No, Saragusa is older. He's not that he's okay to die, but he's at least older. There's a guy for the Baltimore Ravens that just died in his home. I'm trying to think what the guy's like, Jawan something or something like that. He's a defensive lineman.
I think it was a 26-year-old.
He's 26 years old. Yeah, found dead in his home. Just collapsed dead, and they don't suspect any foul play. There weren't any drugs present, and unfortunately, he had COVID last year. So there's a chance, Jalen Ferguson, thank you, Anthony. I couldn't remember what his name was. I appreciate that. I'm bad at names. I don't even know Anthony's name half the time. But there's a chance that that could have been a cardiomyopathy. And there's been a couple now cases of athletes with cardiomyopathies just keeling over lately. So congestive heart failure, once it sets in, it's setting in and you're along for the ride at that point. You're not going to reverse it. So for us, we want to monitor their vitals, right? RPE, shortness of breath, pain. They need to exercise. Even though the heart is weaker, they still need to exercise. They may need an ICD. What is an ICD? Just in case you encounter that term and you don't know it. Does anyone know what else an ICD is?
Is it an intermittent compression device?
Nope.
Oh.
Good guess, though. An ICD is an implantable cardiac defibrillator. Implantable cardiac defibrillator. So it's exactly like it sounds, right? So you know what a pacer is, right? A pacer is a pacemaker that helps the heart keep rate. A lot of those pacemakers are also ICDs. And what it does is they have just enough charge that if the patient goes into defibrillation, yeah, it could show up as AICD. Yes, you're right, Joe. It's usually just ICD in the clinic. Thank you. An ICD is literally, it's have enough charge in it that if the patient starts going into defib or VFib, that it can deliver one shock to the heart. And it monitors their heart rate. And, you know, if the patient starts going into it, it can deliver them one shock and at least maybe keep them alive long enough to get care, right? How would you know if a patient has an ICD or a pacer? Let's say a patient collapses and you have to do CPR on them.
I know with a pacemaker, you could see it.
Yes, you
When
can see
you
both.
close their chest. Oh, okay.
Yeah. Right, which is why when we're doing, what do you call it? Doing compressions, we should want to expose the patient's chest. Right, now, good news is if the ICD shocks the patient, you're not going to get shocked because that shock is delivered specifically to their heart, right? Versus, you know, when you put the defibrillator on them, yeah, you definitely want to get away from them because you will get shocked. There was a whole odd stories in the ER I was watching the other day where the doctor was giving the patient epinephrine when the nurse actually delivered the shock to the patient. And so they had the needle, which was metal, pushing it into the patient, and then the defibrillator arced to the doctor and put the doctor into VFib. So now they had the patient that was out with heart attack and the doctor out with heart attack. So I was like, ooh, that's bad. What is an LVAD? Have you guys heard or anyone seen an LVAD before? And right now you may be seeing the term for LVAD is bad. Any of you encountered it? Grey's Anatomy, okay. What they actually have it on LVAD? That's pretty impressive. Left ventricular assisted device, good, right? And the main thing right now that a lot of people are saying the LVADs are bad is there was one specific brand of LVAD that had a high failure rate. Right? So if it's a left ventricular assistive device, that means it's going to help pumping the blood to where? Yeah, the aortic arch of the body. Good, right? Yeah. So an LVAD is there to help the patient pump the blood out to the body, right? I guess I'll have to watch. Was there a whole show about the LVAD on that? Or is there just somebody walking around with it, Riley?
There was actually a whole story arc about a guy who had an LVAD.
Oh, I might have to watch that because that might be the only episode I watch of that show. Because I can't stand it. It's too much love story for me. If I want to watch a love story, I'll go watch WWE, okay? It's great love stories in it. It's men's soap opera, right, Anthony? Glad you agree with me. All right. So if they have an LVAD, if they have a pacer, most of them will tell you that should be in their chart, right? If they have any of those three, what modality is contraindicated?
Easton.
Easton, yeah. That's the major thing. You guys got to be safety-wise aware of those, right? Now, let me ask you, if a patient has an LVAD, a pacer, or an implantable cardiac defibrillator, Could we do e-stim on the ankle? Potentially, right? But that needs to be decided by the PT. That's not going to be a board question, but in real life, like I just had somebody ask me, somebody write an email to me that was a former PTA, and she says, "Hey, I've got a patient. The PT wants me to do Russian to his left bicep, but the patient has a pacer. I thought that was contraindicated." And I'm like, ugh, I would not do e-stim to the left arm at all, because that is way too close to that pacer, right? But maybe the ankle I might do. Maybe, I don't know if it's a quad, I might do e-stim, but you just got to be careful, and definitely not. And for the boards, e-stim is contraindicated. And then that congestive heart failure can lead to any of the other cardiac issues as well. Hypertension, or HTN, the main thing that causes it is nutrition, specifically bad nutrition. So having a McDonald's diet. I forget if any of you ever remember watching that movie Super Size Me. His cholesterol levels skyrocketed, if I remember correctly, from eating that McDonald's for the month. I forget what it was, but it was something really crazy from just eating McDonald's for the month. That's a great show if you ever get a chance to watch it. It is a hereditary disorder. Renal diseases can cause it. All of that fun stuff comes along the lines when we're talking hypertension. For us, we're going to monitor their blood pressure. They do need to exercise regularly. And, eventually, if the hypertension gets bad enough, we have to teach them safety, energy conservation, and compensation, right? Yeah, there we go. 100. Yeah. So any of those are at high risk. Yep. And definitely 25-pound weight gain. That surprised me. And so we're going to talk about psychiatric disorders briefly. And unfortunately, for those patients that have psychiatric disorders, the main medication they give them is lithium. And lithium will increase your weight up to 50 pounds. So that then puts you at risk of hypertension and all the heart disorders. A myocardial infarction can be caused by a clot or an aneurysm in the heart. It can be caused by any previous heart issue. If the patient has an MI, that is different than their heart stopping, right? Because at that point, there's actually a rupture in the blood vessel of the heart at some point, or a clot somewhere in the heart. Monitor them for chest pain. What is the signs and symptoms of my MI for the man, right? It's localized chest pain in the left chest cavity, pain going down the arm, pain and numbness going down the arm. Usually it can go up into the left side of the jaw. And then for women, it's usually a sensation of, women, it's a sensation of heartburn is often. Yeah. Sorry, I lost train of thought there for a second. Valve problems. So if we have valve problems of the heart, this is particularly of the heart. So we're talking either bicuspid, tricuspid, all those valves in there. It is typically hereditary. Most people that get valve problems have a family member that has had valve problems. And usually the term you'll hear a lot is valvular prolapse, right? So valvular prolapse is your valve opens and closes like this, right? Valvular prolapse is where it opens and then you kind of get like this, where they have that little gap. So Brooke, it could be MI, it could also be COPD. Both of those make them feel like they have an elephant sitting on their chest. Yeah. So either way, I'm worried about it, right? But with valve problems, there's not much we can do about it. We just monitor their heart symptoms. And the main thing with valve problems is exercise vitals are going to be weird. So they're not going to react normally, right? So if we put them on a treadmill, we expect their heart rate and their blood pressure to go up. For patients with valve problems, sometimes they don't. And we have to understand that if we see those weird heart issues, we may want to stop whatever we're doing and change activities, right? So for valve problems at that, what is eventually the only way to fix a valve problem?
Surgery?
Yeah, surgery, replace the valve. And what do they usually replace it with? Does anyone know?
Isn't it like cow or porcine?
Yep, cow or pigs. Yep, they're going to replace it. So at that point, hey, at least you got some bacon in your body, right? That's the way I look at it. It proves bacon is good for you. That's all I'm saying. All right, so that's it for cardiopulmonary pathology. What if you're vegan? I don't know, Anthony. You're gonna have to ask a vegan, are they allowed to have a valve replacement? That's be a. I don't know if that'll go over well, Anthony. I'm just saying. All right. So that's it for that. The only thing I didn't put in here overall is I didn't put the psychiatric disorders in there. And the main reason I didn't put a lot of the psychiatric disorders in there is because it seems like they're becoming less and less prevalent and becoming more and more prevalent in the OTA exam. As far as psychological disorders, the ones you really kind of have to understand is depression, right? And what can cause depression? Yes, that's what can cause depression, right?
Studying for the boards.
Yeah, well, yeah. I mean, for the boards, just understand that depression can literally be caused by anything. I would be willing to bet we're going to start seeing an increase in depression after today. I'm just saying. So with depression comes along all those symptoms of depression, feeling of hopelessness, weight gain, signs of doom and gloom, all those fun things. Do you have to know the specific personality disorders and the nervous disorders and the affective disorders? For your score builders, they have one page on it. I would recommend at least looking at that page, but closer to your boards. My book, it's page 495. I don't know what page it is on yours. But if I'm a person that's worried about my boards and I'm worried about what to study and what not to study, psychological disorders are kind of low on my totem pole, right? Because they're not officially classified as a neurological disorder. They are classified in other systems, I believe, if I remember correctly. So I'm more focused on neuro, cardio, musculoskeletal. If I have time, I'll go review my psychological disorders, because I had a couple of you send me a message, because I think there was a question, I think it was either on the PT final exam or it was a score builders exam, that brought up body schema disorders, where the patient, they had a problem with their actually body schema. And again, likelihood of that being a question you get on the boards. You're more likely to get a question on the boards for psychological disorders about depression or schizophrenia. Those are the two main ones.
The answer to that one was anorexia.
Yeah, anorexia nervosa. Yep, exactly. It was a schema question, right? And remember, just focus, one thing about that is anorexia itself is just a what? Not taking in food. That can happen to old people too, or somebody that wants to die. Anorexia nervosa is the schema issue. Does that make sense? Right? Just like bulimia can happen to any of us. We could get a disorder where it's just every time we eat, we throw up. But bulimia nervosa is the schema disorder. So anytime they add that nervosa onto the end of it, that adds the psychological designation of that at that point, right? I'm pretty sure I'm pretty sure even like the cutting disorder has a nervosa attached to it. I forget what it is specifically, but so yeah, body schema disorders just, or the patient doesn't feel comfortable in their own skin. And I would be hastened to say that we all have a little bit of a schema disorder, wouldn't you? And we all aren't 100% comfortable the way we look, and we all try to improve a little bit. So I'm saying that we all have a little bit of a schema disorder. And it's just all the way we manage it. People that actually end up with schema disorders, unfortunately, can't manage it. So just be aware of, don't focus heavily on the psych disorders, is all I'm saying. All right. So last thing I want to talk about, because I really need to hit this research thing, because I think they have successfully totally confused you for research, unfortunately. Does anyone feel that way with the PT final exam, that they confused you a little bit on research? Just a little? Okay. And the reason I felt that they're confusing a little bit is mainly because they talk about, how did she put it? I'm trying to think of the way that they put it that's confusing. They don't talk about ruling in or ruling out a condition. they talk about chances or something like that. I forget the exact term they use. But for your boards, it's going to be ruling in or ruling out. Okay, so that's where we get into the spin and the snout rule, right? So specific, I'm going to type it in the chat. Test positive, rule in. And this is the rule that honestly will help you with your boards. I know that they were going to do a lot of it. How did I spell positive wrong? That's impressive. That's positively impressive. See what I did there? I am funny. So a specific test, a test that is high in specificity, and you have a positive result, rules the condition in, which means the patient is likely to have that disorder. If you have a highly specific test and you get a negative result, what does that tell you? So if you have a, oh, I saw a duck there. I was getting concerned. Here's the question. Okay.
Can you repeat the question?
Yeah. So if you have a specific test, highly specific, so 0.98 specificity, and you get a negative result, what does that tell you about the patient?
They don't
Yeah.
have that condition.
In reality, it doesn't tell you much without looking at the sensitivity. Right? So you have to look at both. So a specific is just for kind of ruling stuff in. I'll look at that in a second. I just saw duck and I'm like, why are you it looks like your link has duck in it for some reason. I was like, why is he sending me a duck picture? So specific tests with a positive result rule in. And I'm going to be honest, when you're doing research, this is what most researchers go by. A sensitive test that gets negative results rules it out. So in order to have a good test to rule in or out something, you have to have both high specificity and high sensitivity. That would be a really good test. That would be a good test, raise the roof test, right? But if they're altered, where one is low or the other is low, then it's only going to rule in or rule out. It's not going to do both. So let's say I've got a test that has a specificity of 0.99, but a sensitivity of 0.40. That is really good at seeing if you have the condition, but it's not really good at seeing if you don't have the condition, right? So if you get a negative result, they still could have the condition. It's unlikely, but they still could. Right? There's a chance. There's a chance for that false negative to happen. Versus a test that's high in sensitivity and low specificity, getting a positive test doesn't tell you much, but getting a negative test definitely says you don't have it. Like right now, the at-home COVID tests, they're kind of mediocre for both specificity and sensitivity. They're a little better than flipping a coin. But what they could tell you is if you get a positive result, go get a PCR test, which is a lot more specific, right? I like to use those tests because they're current to where we are right now. But something like a Thomas test. A Thomas test is really, really specific. I want to say the Thomas test is like 0.98% specific or something stupid high like that. That means if you get a positive Thomas test, what does Thomas test for? Do you guys remember? Hip flexors, good. Hip flexor tightness, right? So if you have a positive Thomas test, there is a really good chance you have tight hip flexors, right? I don't think the sensitivity is that high on that one, if I remember correctly. But anyway, let me look at this question that Joe sent me. I'm going to bring the question up. So let me bring it into a separate window so you guys don't see all the windows I have brought up that I'm looking for protests today to go to. I share my life with you guys, but not that much life. All right, so this is a test question he brought up. So prior to a follow-up visit, a physical therapist is reviewing physical therapist evaluation. PTA, notice that special test was used, has best evidence to indicate an individual with a condition of interest that have the condition. Okay, well, that's good. I mean, overall, that's actually fairly good writing, right? So if you're trying to see if they have it, you want a high specificity. High positivity likelihood ratio, that goes back to like the alpha value. Don't worry about that, right? What high validity? When would it be high? When would you want a high validity? What does high validity tell you? Well, I got chat. I can bring my chat up. I'm like, no one's answering me. The test is valid. Good, right? This question messed with my rationale. What's the rationale? Yeah. High validity literally means that the test is actually testing for what you should. Right? It means it's a valid test. It's going to be something that's, you know, repeatable, quality, stuff like that. This is incorrect. Positive likelihood ratios to find is the likelihood that positive tests will be obtained in a patient client with the condition of the interest is compared to a patient client without. That's a really, really specific way of saying that your alpha value is positive. Anyway. Yeah, so it's intended to measure. Good. So at least I got that right. But yes, so a highly specific test is good for ruling in. A highly sensitive test is good for ruling out. Right? So that's the main thing for your boards. So let me close this screen share and just bring up my whiteboard real quick. Because that way I can write here. All right, so I got my whiteboard. So let's put a couple different tests up here. So we have specificity of 0.97, sensitivity 0.98. I'm going to put 3 tests up here. First of all, with these numbers, what is the number you're looking for a good test? Over what? The highest, good, but over what? Yeah, 0.7, 0.75, somewhere in that range. All right, so I got 3 different tests up here. I have one that's specific 98, sensitive 90, or specific 97, sensitive 98, specific 88, sensitive 50, specific 50, sensitive 93. Which of those tests is the best overall test, A, B, or C? Yeah, top one by far. A is the best test overall, right? Now, let's say we take A out of the equation. So A is gone right now. So it's gone. And you get a question that says you are attempting to rule in a condition, B. Good. That would mean C is to rule out the condition. But looking at both B and C, if you get the opposite result, say they're saying you have a test that is test B. So it's specific 88% of the time, sensitive 50% of the time. And you get a negative test. What should you as a PTA do? Continue further testing. Right? Because then you need a test that's sensitive to rule it out. Because that test tells you really nothing. It's literally you picked up a coin, you flipped it, if that they don't have the condition. Right? So this one up here, right? Would that have a chance at a high false positive or a high false negative?
High false positive.
Think about that. It's really specific. So positive, good. This one has the chance at the high false negative, meaning the patient still may have the condition. They may fall in that 12% that it didn't show up right, right? So a negative in that case doesn't tell you anything. That's what a high false negative means. A negative doesn't tell you anything. Does that make sense? A high false positive means the positive doesn't tell you anything. So like right now, there's one specific of the COVID test, and I think it's the biactive. I don't remember which one it is. But that one has a real high specificity. It's like 0.88%, but the sensitivity is like 0.4. So it's really good to see if you have the condition, but if you get a negative, that doesn't mean you don't have COVID. That just means that test didn't show you that you have COVID. Does that make sense? So you could still have COVID. You probably should go get checked again. So just be aware, you're not going to get a question on high false positives and high false negatives. But if you get into research, you have to understand that concept. Does that make sense? Okay. So does that help clarify those a little bit, at least make those a little bit more bearable? So your main questions, yeah, you're not going to have to know the specificity and sensitivity of tests. They're not going to do that. That's not me. That's mean, right? But they may say this test, and here's their specificity, this test, here's the sensitivity, right? That's where you get down and pick what you have to pick. Other than that, what is the best type of evidence? Research. What is the top of the research pyramid? Yeah, meta-analysis, good, right? Randomized control trials like right below it, right? So the meta-analysis or the systematic review, right? That's where you go and you get a ton of research that other people have done and you bring it together, right? Next would be the RCT, the randomized control trial. Good.
They asked us a question on Maslow's hierarchy of needs. Do you think that's bullcrap? Like that's like some old PT thing, or?
Well, I mean, Maslow exists. Okay, hey, look, I happen to believe in Maslow psychology. Don't tell me it's bullcrap. No, just kidding. It's unlikely you'll get a question on it. How about that? Is that fair enough for you?
Yeah, because I had no clue what the heck it was. Never heard.
What is Maslow's? For those of you that have taken psychology way back in the day, what does Maslow's tell us?
It's basically like how, like what needs need to be met, and like their basic needs, and then like the higher up you go, the higher functioning you are.
Yeah, until you get to self-actualization, right? Where you can be your best person. And basically Maslow says, if you don't have shelter, you know, you don't have a need for a computer, right? That's kind of the idea, right? Now I would counter that in today's day and age, I think, because one of the things we used to say is, well, if you don't have shelter, you don't have food, you don't really need a phone. Well, in today's day and age, that might be the only way to get food and water, right? Is to have a phone. So I don't know, we're changing a little bit nowadays. I would say that phones are right up there on Maslow's hierarchy of needs nowadays. I'm just saying, even for like 5-year-olds, they definitely need phones to text with, right? Jason, your kids need it? No, just kidding. Hopefully your daughter's not listening, because I just told her she needs a phone. No, just kidding.
She has a phone right now.
Oh, okay.
It wasn't my deal.
It's like, I just went along. That's okay. So let me see what you brought up here real quick. As far as what you need to know as far as your the boards for that, Joe, understand that typically nominal means named, right? Nominal usually means that the research, like the stuff that you're looking at, has a specific like name to it. It's categorized. Whereas ordinal typically means numbered, right? Scaling, stuff like that. And then the rest of the way up is are you likely to get that? But you might get a question. Yeah, ordinal would be RPE. Ordinal would be your pain scale, right? Nominal, if you really want to do nominal would be your description of pain, right? So Berg would be ordinal. Wait, I think Berg would be ordinal. Yeah, I think maybe. Both. But definitely description of pain would be nominal, right? Telling it's achy, burning, whatever, that is kind of a name for it. I'm not torn on the Berg here, Anthony. Now you made me second guess myself. But definitely if they say that, you know, you're gathering a patient's pain and you take the pain on a numeric rating scale, what type of data is this? That's ordinal data. And for the most part, your ordinal data goes in what part of your SOAP node?
Ordinal, objective.
Objective, yeah, the numbers, right? The ordinal typically goes in objective. And honestly, most of your nominal will either go in subjective or assessment, right? So if you're saying the patient has hypertension, that is a nominal description of an ordinal number. Does that make sense? So that would be more of an assessment at that point. According to PT final, Berg is nominal. Yeah, that's what I'm like. I'm like both. I'm kind of torn there. Technically, even numeric rating scale could be both, because you have a lot of pain, no pain, right? There's a little bit both there, but we typically consider it ordinal. For the most part, when you're doing research, you kind of want more ordinal data, right? You would want more data that is able to do math. We learned about that in physics. Math is the language of research, right? The more numbers you have, the more you can quantify and qualify something. So I wouldn't totally get lost. I mean, that's a good chart, Joe. But again, your research is in safety and protection, and the likelihood of you getting a specific question on that is, again, research, you're going to get more on specific sensitivity, the quality of the research. So obviously a single case study, anytime you see that, that's kind of like the worst case scenario, right? If I do a case study on Jason, what does that tell me about the community? Pretty much nothing. It tells me about Jason, right? Now, if I did a case study on Jason and 9 of the other people that live in Pahrump, right? Now I'm starting to get a little bit more specific and getting a little bit more of a data set, right? So that's kind of the idea. And Jason's like, I won't match up with anyone else in Pahrump, so go ahead and do that.
Last question for me. What are the chances of respiratory or metabolic alkalosis, acidosis?
Know the basics of it. Just know what they mean, the definitions of them. And then what I would say is understand if they have respiratory acidosis or respiratory alkalosis, what does that do to the blood? Does that make sense?
Yeah, if it's decreased, it's acidosis. If it's increased, it's alkalosis.
Yep, good. That's it.
They had like
no symptoms?
bicarb questions, I think.
Yeah, well, so there's not going to be specific about bicarb. I mean, what bicarb is going to use to treat which condition, though?
Metabolic, or is there a kidney? Is it renal?
It's typically renal. Yeah, typically renal acidosis and alkalosis. Typically, yeah. So again, but that's medication and that's kind of diagnosing. But again, bicarb, that's really specific. I'd be more worried about your meds for the heart than I am that. And what did you say, Jason? I'm sorry. I cut you off.
I know. I got one of the practice tests. I got a question about symptoms of acidosis or alkalosis.
In breathing, typically, was it in breathing?
I don't remember the exact question.
Probably for that it's knowing what type of breathing the patient should do, whether it should be short and shallow breathing or deep and conductive breathing.
It was if the patient had acidosis, what would they present with? It was basically that. And I know I got it wrong because I don't know the different symptoms of either one of those, but is that something we should know for the board?
Oh, for as far as that would go, that would be something I'd look on like one of my last days.
Okay.
Right. Just that's when you're getting to the cleanup portion of your boards. Does that make sense? I liked your music. That was good. And the values Quizlet. Let me see those. Oh, is this a Quizlet on the values? Good. Yeah, that actually is most of them now that I see it. Let's see. Sign up and see the remaining cards. It's free. I don't know how to sign up. Yeah, so that's actually a good list of them. But as far as it goes, I mean, I'm not really worried about partial pressure of CO2 and partial pressure of O2 and when I need bicarbonate and when I don't need bicarbonate. I'm more worried specifically about can I identify what the changes in the blood happens, right? What I might cause it. And the main idea there is that, certain medical conditions may cause certain of those conditions, right? Trying to think if there's anything else in the research I'm really worried about for you guys. Not really. I mean, you guys, you're okay on mean, median, and mode, right? That's not a silly question. You guys know the basic maths of that, right? That should be okay. They've taken out a lot of like the alpha value and the p value, which should make you happy. That you don't have to be able to, you don't have to identify what an alpha value is versus a p value. So that's a positive for you. They had questions back when I went through that they gave us 2 alpha values and p values, and we had to determine what the research told us. And that wasn't fun. That makes your head hurt, right? So you're lucky that they've kind of pulled that out overall. Oh, the other thing that kind of falls that when he mentioned Maslow's hierarchy of needs, the one that I have, for whatever reason, heard of popping up quite a bit is Kubler-Ross's stages of death and dying. I know there was Riley's face, right? But the good news is most of those are pretty descriptive for what they are, right? So what are the stages? Well, you got denial, anger, bargaining, depression, and then acceptance. And understanding that not all patients go through all the stages. It's just like C-band for cold items, right? And then not every patient reaches acceptance, right? Hopefully you all reach acceptance that you're going to pass your boards and you're not in the stages of Kubler-Ross's death and dying at this point, right? But I guarantee, and I've seen it before, like when people fail a test, not necessarily this test, but any test, they go into the bargaining stages. Especially with me, because I had somebody come up to me like, well, Mr. McKeever, what if I did a little extra work? Could I pass that? No, it doesn't work that way. I can't help you with the boards anyway. But I mean, the names tell you what it is. Denial, they're denying their condition. Anger, they're mad at having their condition, right? Bargaining, they're trying to trade off and on to get out of it. Depression, that makes sense. And then acceptance, right? So if you got a question, the patient said the patient is in stage 3 cancer and says to you, if I do my exercises, my cancer will go away. What stage are they in?
Denial.
Either bargaining or denial.
They could be in either. Yeah, right. Which one fits better though?
Bargaining, really, because they're,
yeah.
If I do this, then this
yeah,
will be better.
bargaining. If you get a question on bargaining, it's going to be an if then that. Does that make sense? Denial would literally be, I don't have cancer, right? The doctor misdiagnosed me. I've got a family member right now that I recognize right now is in the beginning stages of Parkinson's. Like everything, this like resting tremor, problem walking, all of that. Like I'm sitting there going, this is literally like I could present his picture to you guys and all of you would 100% of the time go, he has Parkinson's. And he's like, well, you know, a few years ago, I was at a wedding and I was in the shower and I was holding onto the handle while I was showering myself off. And that handle came off and I smacked myself in the forehead. And I really think that's what's causing this. He's got both. He's in denial of having Parkinson's, but now he's trying to bargain and say it's a head trauma. Well, guess what? Parkinson's can be caused by head traumas, dude. I'm just saying, right? What if I said that your patient comes to therapy and is constantly contradicting you about the condition they have? What stage are they in then?
Anger?
Anger. Yeah, they're in the anger stage at that point. Right? That when they everything you say to them, that's not necessarily denial at that point. When they're contradicting everything you say, like, no, I don't have this. Could they theoretically be in denial? I guess, but if they're really kind of saying, this is what it, no, that's in that anger phase. They're starting to move along that process. They're getting a little better then, at least. They're out of full denial. They're into anger, but they got to move along, right? And acceptance rarely happens. Usually, unfortunately, most of the people that end up with acceptance are the ones that end up dying of a disease. They finally eventually say, you know, this is what I have to deal with. And some people that are dying even don't get there. I would hate to have to go through this for myself. I don't know if I could do. You think angry Mr. McKeever would come out? It'd come out pretty bad then. I'm just saying. I'd be stuck in anger the rest of my life. Sometimes I get stuck in the phases of death and dying when I get your Compass Pro reviews. I didn't do that. But yeah, so just review those. I mean, it's not the big thing. And for Joe, just to let you know, on at least in my book, it's page 699. Maslow's hierarchy is there if you just want to look at it. What I'm going to do then is that's supposed to be covered in Rehab 1. So I'll just remind the current instructor of Rehab 1 to kind of review Maslow's. Because both Maslow's, and I know stages of dying is in growth and development. I thought growth and development also covered Maslow's, but maybe she doesn't. So I'll just have them re-hit it.
Maybe she did. I don't remember.
I remember Maslow's from growth and development.
Okay.
I don't know how far into it we got. I have to pull out my notes.
Well, Maslow's also supposed to be in rehab because we face that a lot in rehab for patients that are homeless. So we kind of need to cover that in that stage as well. I got a question emailed to me asking me about Piaget and development. And do I have to remember the difference between Piaget and development versus Freudian development? And here I am to tell you no. Right? I don't know where one of your classmates got completely hung up. They saw something on Freudian development and Piaget development, and they're like, "Oh my God, I'm in anger versus despair, or bargaining versus despair." No, don't worry about totally on that. They're not going to get totally stuck on those. All you have to know for those is they're typically the psychological development from childhood to adulthood, right? And if you ask Freud, most of us get stuck in the oral phase anyway. So what does it matter? Jason's stuck in the oral phase right now, I can see. So don't totally freak out about that. But
yeah, I got a friend. He's an alcoholic and he thinks he has Parkinson's now, but I think he has alcohol-induced myopathy.
Yep.
And he's just in bargaining or in denial.
He would be, right? Now, could his alcoholism cause Parkinson's? Research is still out on that, right?
Don't you think he's too young at 30 years old?
Yeah, that's what I was going to say. If he's 30 in his 30s, definitely. But what he could have, Joe, is Parkinsonism, where he's showing symptoms of Parkinson because of the alcoholism. Does that make sense?
And then he's living in Nebraska and just like what he's like pretty much showing everything on his Facebook, you know?
Oh yeah.
And
I've got Parkinson's.
He says he has a grade 3 sprain, and then I'm thinking in my head, grade 3 sprain, that's a torn ligament. You can't walk. Like, so I know that he's like just making up things as he goes to get pity from people online.
He's going to Dr. WebMD. Is that what you're saying?
I mean, he has to, because you wouldn't even be able to walk, man.
Yeah, no. And ironically enough, Joe, the family member that I was talking about, guess where they're located at? Nebraska.
Yeah, he's out in Omaha.
Yeah, so maybe it's a thing in Nebraska, Joe. Maybe it's just a thing those people in Nebraska.
I'd be drinking if I was out there.
I'd be drinking if I was in Pahrump, but what do I know? I just have to pick on Pahrump every now and then. Again, it's the only place I've ever been chased by a guy in a full bear costume, so... And the sad part is Jason can't say that doesn't happen in Pahrump. He knows that absolutely could happen in Pahrump. Every time I see live PD or I saw cops, I always like, okay, when's the episode for Pahrump going to be on? It's coming.
That show was so bad for us. I wish they never agreed to do that.
Well, it's not only bad for you, but also Pima County was another area it was bad for in Arizona, to be honest, because Pima County is kind of like the Pahrump of Arizona. Or not Pima, Pinal County. I'm sorry, Pinal County. All right. Again, I didn't want to cover a lot on research. I just wanted to make sure you guys got the spinets now, because that's going to be the majority of what you have to cover. And then make sure that you understand that pyramid of research, right? The pyramid of research also then goes to the pyramid of evidence-based practice. where you have to have research in that pyramid in order to have a good quality practice, right? Evidence, skill, previous patient treatments. So all of that comes into the same thing. Just made this. There you go. That looks good. Yeah, that actually is really, really good, Joe. I may steal that. I'm just going to tell you. I'll put. I'll put courtesy of Joe, who passed his boards on the first try. That's what we're going to do. All right, Brooke, I see that. Which Mark? Are you talking? Oh, yeah, okay. Yeah, Mark's out in clinicals right now, so we'll see how he does. They're all out in clinicals right now. This is where I get happy because everyone's now Dr. Reskin's problem. No, just kidding. Actually, no longer, because now they're my problem too. Now being in program director, right? Yeah, they were all nervous. They were really nervous about going on clinicals. They were more nervous than you guys were. Like, so. Although I will say this, I just saw one of the schools on the West Coast. They were just doing a study on this. One of the schools not on the West Coast, on the East Coast, I think it was one of the North Carolina schools, was petitioning to have their PTA program be 85 students in 2 cohorts. You know, like, can you imagine that clinical director trying to find 170 clinical placement slots? It's impossible. I feel bad for Dr. Reskin having to find 50 sometimes. She does amazing jobs, though. Tell them third rotation's hardest. I've kind of warned them. But, you know, they're going to come back just like you guys did from your second rotation. They're going to be know-it-alls in 5th semester. So that's all that matters. All right. Are there any other questions? So what do we have coming up? Let me see what I have scheduled for next. I had something specific scheduled for next week. So really, I mean, next week's kind of the last week. So what I would like from you guys going into next week, if you can for me, I think I just had like a neuroanatomy review. I think I've scheduled for next week. Because I want to hit all of the spine, the diatoms, myotomes, blah, blah, blah. I know but what I want from you guys over this next week is send me, if there are specific questions like you have there, send me those specific questions, because then we can go over them as a group. It doesn't matter if it's score builders, doesn't matter if it's therapy ed, it doesn't matter if it's PT final, doesn't matter if you're using one of the other sources, because academically, I can review all of them. PT final can't review score builder stuff. Score builders can't review PT final stuff because proprietary. But I'm a school, I can review whatever I want. I'll do what I want. I'm going to get cited for that or something. So send me any of those questions you have. If there's specifics, like maybe you want me to review pediatric reflexes, or maybe you want me to review the lung chart, just so that you kind of get understand the lung chart. Send me specific things you want to review as kind of a final touch-up. Even peak questions, absolutely. Lung chart would be good. Yeah, I can. How about I just add that already for you, Brooke? How about that? Lung chart. And then before I kind of close up and let you go, I just want to make sure that it's on recording here. Did you guys get an email about graduation? All right. So I thought the email was sent out already, but I guess it wasn't sent out already. They have finalized the plans for graduation. Graduation is now on the 19th is when they changed it to. Because UNLV evidently had something going on the 4th, so we had to change it. Yeah. Oh, the diploma. There's a reason why you guys didn't get your diplomas, by the way. I'm not going to say it was my fault.
I got mine.
Oh, you got yours? Did you get yours with the signature?
Yeah, I got mine.
Okay.
I don't know. I didn't really look at it, but
Okay. So if you didn't get me your diploma, send me a specific email with that. Because don't add anything else to it, just diploma. Did not get it. Did you guys see that my signature was on that? That was a lot of pressure. They sent me an email saying that's why it was delayed, because they didn't know who was supposed to sign it.
Actually, I
had-
was waiting to pass the boards before I opened the envelope.
Oh, okay. So then wait till then. So whatever you choose to do. I'll look into the diplomas. I'll put that down as my list here, but they should have been given out. But that was part of the reason why the diplomas were delayed. Evidently, they were over in the registrar's office and like, well, who do we get to sign it? And so I got the,
It does have your signature. I didn't even notice that.
yeah. And Libby made me feel bad because, man, Libby's signature is pretty. She's got it all. But I'll look into those guys, you guys that didn't get it. So the graduation, like I said, is the 19th. I want to double check what time. I want to say it's 4 o'clock, but I want to just double check it. (19th) at 4 o'clock it starts. So you'd probably want to arrive there early. Like I said, good news is Dr. O'Neill did grab all of your gown size, I believe. I have that on my phone. So I've already forwarded that to you. Hopefully, none of you have directly changed your gown sizes. But I can understand studying for the boards how that could change your gown sizes. I'm just saying. Look back here. Yes, I've got a PDF of your gown sizes. Let me just make sure that none of you didn't give me your gown size. Hold on one second. That are here currently. Hold on one second. It's going to make me sign into my Adobe account because, of course, it will. And of course, it's going to send me a text message because that would be too easy not to. All right. Yeah, so it looks like I've got all of you guys for the most part. If there's any of you that didn't, just shoot me an email, but I've got all of your current ones. Yeah, they're there. Cap and gown. Yeah, I've got everyone's. I got 26 already. So good. I've got all of them. Cap and gowns are Pima Blue. Yes, 819, Anthony. 8.19, 8/19, 8, whatever 19 you want to do. I'm going to warn you, I don't know how many of the faculty are going to be present. I know I will be present, but it is a big event, and honestly, I would prefer, if I can, to just keep the faculty from getting sick, if it's possible, if that makes sense. Because if I get sick, it's easier to have me out than it is to have Dr. Reskin, Dr. Sokel, and Miss Malice out. So I may be the only one there. I don't know for sure. I also have to represent the BSPTA students, so I definitely have to be there for that because we'll have some BSPTA students graduating as well. But it's like Pima blue-ish color. Not quite as dark as my Penn State blue. Do I don't know if I have any pictures from a previous graduation. I don't think I do. No, I don't take pictures, so I don't have any pictures from previous graduations. I don't like pictures because usually people try to take pictures of me and I don't like pictures of me. Yeah, no, I don't have any pictures. Most of my pictures are of my cat before she passed. That's what all my pictures are. I don't have any friends. But we'll order those, so have them. I can't believe they haven't sent out an email about it. Ms. Parrish said she was going to. Maybe she just hasn't gotten a chance yet to. So I'll make sure that email goes out. The only last thing I want to cover before I let go and I talk to those individuals that have to meet with me is once you guys pass your boards and then once you get employed, please do not drop off the face of the earth. I have to verify your employment once you're employed. And I'm struggling right now to get people to contact me back to verify employment. So like, if one of you that have contacts could reach out to Bianca, please. She didn't respond to me when I sent her emails and I need to verify her employment. So if you could, like, those of you that are friends with her could maybe shoot her a text message and say, hey, could you respond to Mr. McKeever, please? That'd be really great. I don't care if she doesn't like me anymore because I eat meat. This has nothing to do with that. I need this for our accreditation. And I also have to send out the survey for her employers. So if you could just kind of reach out to her. I've got John, I've got Truman's. Can't believe Truman abandoned us, guys. Did you see? Do you guys know that? Abandoned us and left Nevada, meanie. He left you. So if you can, please, that'll be the last time you really ever have to talk to me, right? I'm just saying, the last time you'll ever have to talk to me is just verifying your employment. Then you never have to see me again if you don't want to. But please, like when I send that out, verify, please. It makes my life a lot easier. So if any of you have contacts with Bianca, just please nudge her my way. None of you have contacts with the previous cohort, so you won't help me at all. So sadly, I'm looking for 2 from the previous cohort that I can't get verified right now, and it's making me very angry. So other than that, I'm going to stop the recording at this point.